VELA clinical trial is a phase 1/2 study of BLU-222, which is a potent and highly selective oral CDK2 inhibitor being evaluated initially in monotherapy in patients with advanced solid tumors, and then subsequently in combination with ribociclib and fulvestrant in patients with HR-positive, HER2-negative metastatic breast cancer. And I think the reason for the study and the compelling nature of the target is really just that CDK4/6 inhibitors have really changed the landscape and the outcomes for patients with HR-positive, HER2-negative breast cancer. But most patients ultimately progress. And one of the major mechanisms of resistance is CDK2, which is another regulator of cell cycle progression. And so CDK2 has been a target of interest for a long time. And we at Blueprint have been able to develop a highly selective and potent inhibitor of CDK2 and are testing it in this clinical trial. The objective of the clinical trial is to identify a dose that can be safely combined with ribociclib and fulvestrant to initially look at safety and adverse event incidence and profile in patients ultimately with breast cancer, HR-positive, HER2-negative breast cancer, in an effort to identify a dose for future expansion and development into pivotal clinical trials. So I think the most compelling thing about the results of the data that we presented at ASCO this past weekend are that we have been able to safely combine a CDK2 inhibitor with a CDK4/6 inhibitor, which has never been done before. And as I mentioned, CDK4/6 inhibitors have really dramatically changed the landscape and the outcome for patients with HR-positive, HER2-negative breast cancer, but ultimately patients progress. And the ability to combine a CDK2 inhibitor with a 4/6 inhibitor can lead to more complete cell cycle inhibition, which we think is a real opportunity for patients with this disease. So beyond the efficacy and the fact that this is really the first time that anyone's been able to combine a CDK2 inhibitor with a CDK4/6 inhibitor, we were really encouraged to see in the trial that we saw in patients evidence of inhibition of the pathway when combining a CDK2 inhibitor with a CDK4/6 inhibitor. TK1, or thymidine kinase 1, is a downstream biomarker that can be measured in patients' blood. And in the trial, we saw evidence of suppression of TK1 activity in the serum of patients that correlated with the BLU-222 exposure and not ribociclib. So I think this is evidence that BLU-222 is adding to the pathway inhibition that ribociclib provides. Beyond that, we saw in all of the patients treated at efficacious dose concentrations, we saw reductions in circulating tumor DNA in all of the patients in the cohort, which can be an early marker of activity and a prognostic marker on therapy. Finally, we were encouraged to see, although the data is early and the efficacy is immature, we saw 2 patients with partial responses that emerged in the very, very early efficacy data. One in a very heavily pretreated patient with 6 lines of therapy in the metastatic setting, and another response in a patient who began treatment on the lowest dose in the dose escalation cohort and remained on study for many months with stable disease. And after her dose was increased to just 200 milligrams twice a day, she had disappearance of disease in the liver, which we think is really a compelling case demonstrating the potential synergistic activity of CDK2 inhibition with CDK4/6 inhibition. The implications are significant that, in fact, we are showing that we can combine a CDK2 inhibitor with a CDK4/6 inhibitor for more complete cell cycle inhibition. And these are therapies that are used now as the standard of care. The 4/6 inhibitors are standard of care in the frontline setting for patients with metastatic disease and are moving into the adjuvant setting. And so the ability to more completely inhibit the cell cycle has great potential for benefit in patients with HR-positive, HER2-negative breast cancer.